Good afternoon, everyone. My name is Dr. Salil Patkar. So today, thank you for the opportunity. I'll be discussing about bone health in cancer. So let's begin. So cancer and its treatment can have profound effects on the bone health. We are aware of that. Clinicians treating cancer patients need to be aware of the multidisciplinary treatments available to reduce skeletal morbidity from metastatic disease and to minimize the cancer treatment-induced damage to the normal skeleton. Metastatic bone disease is most commonly seen with specific cancer types, notably those with mets from the breast, which accounts for 70%, prostate 85%, lung 40%, kidney again another 40%, and of course multiple myeloma when nearly all patients are going to present with bone mets. Bone metastasis most frequently affects the axial skeleton and often causes skeletal complications, which we know as SREs, which includes pathological fractures, radiotherapy-induced damage to the bone, surgery to the bone, spinal cord compressions, and hypercalcemias. So what is the pathophysiology? Why are bones affected so commonly? Because most disseminated tumor cells die, but a few will survive, and the bone microenvironment may act as a favorable environment for the colonization of these malignant cells, serving as a place where they can harbor and grow eventually. Hematopoietic stem cells, osteoblastic, and vascular niches within the bone microenvironment have all been suggested as a sanctuary for these disseminated tumor cells. Thereafter, DTCs can enter a dormant, non-proliferating state sometimes, particularly in breast cancer and prostate cancer for many, many years. Why these cells then again become reactivated and then lead to cancers and metastasis in these bones is something we don't know for sure. The diagnosis and monitoring. How do we diagnose and monitor bone mets? So imaging can be divided into two predominant ways. Structural modalities such as plain X-rays, CT scans, MRIs, and metabolic or molecular imaging tools, which include diffusion-weighted MRIs, PET CT scans, and single photon emission CT scans or SPECT. So let's go over some of these in a little more detail. Plain X-rays, not so commonly used anymore. Yes, they serve as an initial approach. However, they are not very sensitive. For a destructive lesion in a trabecular bone to be recognized, it should be at least 1 centimeter or above, with a loss of almost by weight 50% of the bone mineral content. CT scan, on the other hand, will show bone destruction and sclerosis, as well as any soft tissue extension will be very well visualized. However, differentiating between metabolically active versus inactive bone lesions cannot be done on a CT scan, which makes it of a very limited use when you are re-evaluating a patient post-treatment for improvement. MRI is useful for evaluating patients with positive bone scans and normal X-rays and for elucidating the cause of a vertebral compression. MRI is more sensitive than bone scintigraphy for detection of spinal mets and essential for treatment decision-making in patients with cord compression. Coming to the more useful or the more advanced techniques, nuclear medicine technologies using radio-labeled tracers for imaging of metabolic or molecular characteristics of bone metastatic disease. These can be classified as osteotropic or bone-seeking agents that image the osteoblastic reaction induced by the mets, or oncotropic, which are direct tumor imaging agents that assess the metabolic or molecular function. With the exception of patients with multiple myeloma, however, the bone scan is more sensitive than plain X-rays for the detection of skeletal pathology. A PET scan, which is so commonly used now, has significant advantages over bone scintigraphy for evaluation of skeletal metastatic disease, including superior diagnostic accuracy, higher spatial resolution, and shorter imaging times. However, PET is not 100% specific for skeletal mets and does require careful integration of morphological changes with a bone scan on CT or MRI to ensure accurate interpretation. An FDG PET accurately allows differentiation between a progressive osteosclerosis on CT that can reflect either tumor progression or response to therapy. So it helps you differentiate and tell whether and prognosticate the patient post-treatment, which a CT scan may not be able to do so. The diagnostic pathway for myeloma, on the other hand, is somewhat different. As myeloma bone disease is often missed on radionuclide bone scans, in addition to bone marrow biopsy, low-dose whole body CT or an FDG PET imaging are the preferred modalities when dealing with multiple myeloma. A bone biopsy, is it really essential? Well, in most cases, the answer would be no. If you have an oligometastatic disease where the treatment would differ based on whether or not there is bony involvement, perhaps then a bone biopsy could be merited. However, in bone-only disease, especially like I said, when there are few lesions or imaging tests are equivocal, that is where a bone biopsy comes into place. When you have a florid metastatic disease, a bone biopsy is going to add a very limited benefit. How do we evaluate post-treatment? Now, bone is the only site of metastatic disease which has its own criteria for evaluation, of response to treatment based upon the bone repair and destruction rather than on checking for the change in the tumor volume, is which what we do in other cases. Sclerosis of lytic mets with no radiological evidence of new lesions constitutes such tumor regression. The use of bone scanning for assessment of response to therapy is unreliable when lytic lesions predominate. During successful therapy, the healing process causes an initial increase in tracer uptake, known as the flare response, and the scans carried out during this phase are likely to show both increasing intensity of existing lesions and new hotspots. After treatment for 6 months, the bone scan probably would improve. Again, PET-CT has a huge role to play. FDG-PET is the most accurate way of assessing treatment response of hypermetabolic bony mets. Metabolic treatment-induced effects appear much earlier than morphological changes and facilitate rapid treatment adaptation. The PET response criteria and solid tumors criteria are now widely accepted, with partial response requiring a drop of 30% of most active bone lesion. However, the use of PET in prostate cancer is not generally recommended, as increased FDG uptake is only observed in late and more aggressive stages, which is why we have a PSMA PET-CT in this case. Bone biomarkers, are they of any benefit? Well, not really. There is ongoing research, but then it seems to suggest that it is probably of not too much benefit. The sensitivity as well as the specificity is quite low, and they do not provide too much of diagnostic value. Prognostic value, perhaps to some extent, again, not too much at this point to recommend. In terms of treatment, right? So treatment varies when you have bone metastasis. When the patient has bone metastasis, the treatment varies depending upon the underlying disease. External beam radiotherapy, endocrine treatments, chemotherapy, and targeted and immunological therapies, as well as systemically administered radioisotopes, are all potentially important. Treatment decisions depend upon whether the bone disease is localized to begin with or widespread, on the presence or absence of extraskeletal metastasis, and the underlying nature of the malignancy. Let's begin with palliative radiation. Local EBRT is effective for relieving the bone pain. Overall response rates are between 70 to 80%, with complete relief achieved in nearly 33% of the patients. Pain relief occurs rapidly, with nearly 40% of the patients responding within the first 10 days of treatment. A meta-analysis shows that there is not much difference between fractionated treatment or a single fracture in uncomplicated bone mets, especially if the lifespan is going to be limited. In patients with good performance status, pathological or impending pathological fractures of the extremities are preferentially treated with orthopedic surgery to fix or prevent the fracture. Post-operative fractionated RT is usually recommended to prevent prosthesis failure and to reduce the need for subsequent surgery. In patients who have relieved short life expectancies, RT alone may be considered for pain relief. Again, in that, a single fraction perhaps might serve the purpose. Radionuclide therapy. Targeted RT using systemic radioisotopes permits more specific management of the radiation dose to multiple tumor sites with relative sparing of normal tissue compared to EBR. A prime example of is that of thyroid follicular carcinoma with bone mets. The treatment of bone metastasis with iodine-131 is well established. In prostate and breast cancer with osteoblastic skeletal mets, palliation of the bone pain has been demonstrated with bone-seeking emitters such as strontium and samarium EDTNP. However, bone marrow toxicity, as we are aware, remains quite high with these treatments, and the lack of survival benefit makes it of limited clinical use. Radium-223 was approved for use in bone-predominant metastatic castration-resistant prostatic cancer. In the LSY-MPCA trial, patients with symptomatic bone-predominant disease who failed or were deemed unfit for docetaxel received radium-223 placebo every 4 weeks in addition to the standard of care. Patients who were on radium received an improvement in the overall survival by 3.6 months and delayed new symptomatic onset of skeletal events by 5.8 months. The benefits were larger among those patients who were treated with prior or were using concomitant bisphosphonates. An important point to keep in mind. Bone targeting agents. Currently available bone targeting agents includes bisphosphonates and denosumab, both of which are potential inhibitors of the bone resorption. Although RT is the treatment of choice for localized bone pain, BTS provide an additional treatment approach for relief of bone pain that is similar of magnitude to RT and useful across different tumor types. Multiple RCTs have clearly demonstrated that they are effective in reducing the skeletal morbidity of metastatic cancer. From efficacy, convenience, and renal health perspectives, probably denosumab scores. However, from a health economic standpoint, generic bisphosphonates are cost effective, and the issue of rebound osteolysis on denosumab discontinuation described below does not occur with bisphosphonates. I will talk about that. There are no randomized data to guide whether all patients with bone mets should initiate a BTA as soon as bone metastases are diagnosed. Additionally, there is no approved tool to predict which patients will develop an SRE. However, a first SRE often occurs early in the course of metastatic disease. In a pivotal trial comparing denosumab with ZA, 37% of the patients had already experienced an SRE on study inclusion at a median time of only 2 months from the initiation of the bone metastasis. Following careful explanation of the benefits and risks to patients, most guidelines recommend starting a BTA in vast majority of the patients as soon as bone mets are diagnosed and whether they are symptomatic or not. Let's talk about some of the cancers in a little more detail. Breast cancer, bisphosphonates can reduce the skeletal morbidity by nearly 1/3, increase the median time to the occurrence of first SRE by almost 50%, and reduce the proportion of patients having an SRE. Zoledronate achieved the pre-established criteria for non-inferiority to pamidronate, and in a subsequent multiple event analysis was shown to reduce the SRE by an additional 20% as compared to that achieved by pamidronate. Denosumab was evaluated in 3 identical double-blind phase 3 trials in comparison to bisphosphonate naive patients with bone mets. Denosumab was statistically superior to ZA in delaying both the first and the subsequent SREs and delayed worsening of pain. In prostate cancer, ZA is the only bisphosphonate to show a significant reduction in the SRE in patients with CRPC. ZA overall reduced the risk of skeletal complications by nearly 36% and reduced bone pain in at all time points. Denosumab delayed the time to first SRE and produced an additional 18% reduction in the cumulative SREs over ZA. In endocrine sensitive prostatic cancer patients, the addition of ZA to first-line long-term hormone treatment in the Stampede trial showed no evidence of survival improvement. And I would like to also add that there was no delay found in the first occurrence of SRE in endocrine-sensitive prostate cancer patients. Multiple myeloma BTA is always an integral part of the treatment. The Cochrane Myeloma Review Group concluded that pamidronate and chlorandronate reduce the incidence of hypercalcemia, the pain index, and the number of vertical fractures in multiple myeloma patients. Denosumab is statistically non-inferior to ZA in delaying the time to first SRE and extended the median PFS survival by nearly 10.7 months, although no demonstrable OS benefit was seen. Additionally, because denosumab is not cleared through the kidneys, it has a better renal safety profile. Dosing and frequencies of BTAs. The Zoom and the Optimize 2 trials were underpowered for reliable results, but suggested non-inferiority between the 4 and the 12-week schedules initiated after 12 to 15 months of bisphosphonate treatment. In a larger study, patients treated with breast cancer, CRPC, or multiple myeloma were randomized at initiation of bisphosphonate treatment to either ZA every 12 weeks or every 4 weeks. The proportion of patients experiencing a first SRE were similar, 29% in both arms, both overall and in each of the 3 diseases individually. However, more patients who received ZA every 12 weeks ultimately ended up requiring bone surgery. The incidence of osteonecrosis of the jaw was similar and low in both cases. Overall, the results of these trials suggest similar efficacy with dosing of ZA every 12 weeks. However, the follow-up is relatively short, and results of the larger study suggest the possibility of an increase in serious SREs with the extended treatment schedule, and thus an initial monthly approach for the first 3 to 6 months seems prudent, following which perhaps you could shift to the 3-monthly schedule. The pharmacokinetics of, however, denosumab argue against intermittent treatments. Unlike bisphosphonates, like I said, we were going to discuss again. Unlike bisphosphonates, with their accumulation of denosumab in the bone and prolonged duration of action, denosumab does not get stored in the bone, unlike ZA. And there is interruption of treatment, which probably is not without risk. Studies in osteoporosis patients have shown a rapid rebound in bone turnover after denosumab is stopped. Discussing some of the common problems, I am not referring to the infusion reactions. I am not talking about the more easily manageable fever reactions associated with the BTAs, especially ZAs. But let's talk about the more common, the more complicated and the more important reactions, adverse effects that we need to watch out for. First is calcium imbalance. Inhibition of bone resorption by BTAs may cause hypocalcemia. This is more profound for denosumab. The calcium levels should always be monitored, especially during the first few months of treatment, and vitamin D levels should also be assessed. Vitamin D levels are typically lower in cancer patients, and those with vitamin D deficiency should have their levels corrected with oral vitamin D3, 25,000 to 50,000 units per week for 4 to 8 weeks. Vitamin D levels should be maintained with daily supplements between 800 to 2,000 units IU per day of vitamin D3. Calcium supplementation should also be required, and an adequate amount of between 1,000 to 1,200 mg per day. Osteonecrosis of the jaw, an important adverse effect, although not very common, associated with prolonged administration of potent inhibitors of bone resorption. ONG is more common when IV bisphosphonates or denosumabs are administered on a monthly basis for control of meds, and much less frequent with less intensive use of the bisphosphonates or denosumab. Always keep in mind, do our own oral examination, dental examination before starting off BTAs. I'm just going to summarize the recommendations in general. The investigation and management of patients with bone mets or bone lesions should be discussed with a multidisciplinary team with links to all therapeutic modalities. ABRT remains the treatment of choice for localized, moderate to severe bony pain due to bone mets. A single fraction is recommended for painful, uncomplicated bone mets, especially looking at the lifespan of the patient. Prophylactic antiemetics and DEXA to minimize the nausea and the vomiting and pain flare are recommended, especially if you are targeting RT to areas which are associated with increasing the nausea. Post-operative RT should be followed by orthopedic fixation of a long bone or spinal decompression or stabilization. Radium-223 is a valuable treatment option for patients with metastatic CRPC and symptomatic multiple skeletal mets as the dominant site of disease. Currently, it should be used as a single agent with LHRH analogs following previous use and or concomitant use of a BT. Structurally significant lesions in a long bone should be evaluated by an orthopedic surgeon to provide advice on sustainability for surgery. Prophylactic surgery for impending fractures is generally preferred to fixation of after fracture. It is recommended to start with a ZA or a denosumab in all breast cancer patients with bone mets, whether they are symptomatic or not. BTA should be initiated at diagnosis of bone metastasis and considered throughout the course of the disease. ZA or denosumab are recommended in patients with CRPC and bone mets, whether they are symptomatic or not. Bone treatment, other than that, to prevent or treat cancer, treatment-induced bone loss or pre-existing osteoporosis is not recommended for castration-sensitive prostatic cancer. ZA or denosumab is recommended in patients with advanced lung cancer, renal cancer, and solid tumors with a life expectancy of 3 months or more. ZA, pamidronate, and denosumab should be initiated at the diagnosis of multiple myeloma. Denosumab is the agent of choice in multiple myeloma, especially given the renal profile which has to be monitored. Therapy with a bisphosphonate can be interrupted after 2 years in patients with remission. However, the same cannot be said for denosumab. Most patients selected for treatment with ZA can de-escalate this agent safely after administration every 12 weeks, preferably after 3 to 6 months of monthly treatment. Denosumab, for the reasons that I have mentioned, it does not store in the bones. Denosumab should be administered at 4-week intervals. Extended interval beyond this frequency cannot be recommended currently. Discontinuation of treatment after an arbitrary duration other than perhaps for those with oligometastatic bone disease is not recommended. Patients should have a dental evaluation and, when feasible, complete invasive dental treatments before starting a BT. Correction of vitamin D and vitamin D supplementation and calcium supplementation with adequate intake of both is should be maintained throughout the treatment when we are giving BTS. Thank you so much for giving me this opportunity.